Alan Crandall. I work at the Moran Eye Center and the Eye Institute of Utah, both in Salt Lake City, Utah. My main areas of focus are complicated anterior segment cataracts, but also regular routine cataract and glaucoma surgery. First of all, the old adage that the only way to avoid all complications is never do surgery is true. But you can really reduce the incidence of complications by very carefully examining patients, making sure you have all of the instrumentation available to get yourself out of trouble if it happens. It could be pupil size, it could be rhexis problems. A lot of times it's nice to have instruments that will allow you to manipulate through small incisions, that type of thing. And having them available and sort of anticipating that there could be a problem will help decrease the problems as well as help you manage them. Usually the most common complications I see are probably the most common are dislocated intraocular lenses or dislocated bag complexes, usually related to the presence of pseudoexfoliation syndrome, which is actually very common in our area. We have a lot of Scandinavian descents in Utah, a very high pseudoexfoliation population, so all of the potential complications of cataract surgery with pseudoexfoliation, and also the glaucoma associated with pseudoexfoliation glaucoma. Any complication can be very problematic for long-term for the eye. So when I look at a complication, I try to figure out the most important ways to minimize what I'm going to do. An example might be using a capsular retention ring and injecting it through a side port or some other way of keeping a small incision, so you decrease the chance for further complications. So it's understanding when the complication occurs. You have to stop, relax, try to figure out what's the best way, the most efficient way to handle the issue. Complications happen to everybody, and it's always good to have backup sets of instruments, backup sets of rings and things like that might be necessary at the time of the complication. I use the set that I designed for with a Seco. It's a great set to have. This is exactly the kind of thing that you need, and we always have available. We have a couple sets. They're flashed and they're kept sterile for any emergencies. You can use them in a number of different ways. There's a grasper in there that allows me to go in and bring up a lens as long as it's not too dislocated. If it's on the retina, we don't do that, but almost anywhere else within the eye, I can grab that with the micro grasper through small incisions. Again, the advantage of that is the stability of the anterior segment. So once you've made an incision, if it's a large incision, then it makes it more difficult to manage these complicated cases. So having micro instruments that go through stab incisions allows me to manipulate to bring the IOL diaphragm up. There's an intraocular needle holder that I can use to pass sutures through ab internal to stabilize a risky cataract patient. I can use it to go through a Sione ring eyelet and stabilize the lens to the sclera. I use them all the time for when I use a three-piece lens, I'm going to suture to the iris because it's the easiest and safest way to manipulate inside the eye. And I love the scissors because you can, again, they're small incision. You can visualize what you're doing. You're not tugging on iris. You're not risking any issues. You go across the eye, visualize, and cut the sutures exactly where you want them. Subluxated IOLs can happen from one trauma, but the most common situation we see it is in pseudoexfoliation syndrome. We did a large study looking at spontaneously subluxated lenses, and it turned out that the vast majority of them were in patients with pseudoexfoliation syndrome. The average time following cataract surgery was about 8.5 years, but as early as 6 months and as late as 20 years after surgery, the IOL lens complex would spontaneously dislocate. It's related certainly to the zonulisis that occurs spontaneously with pseudoexfoliation syndrome. It happens with retinitis pigmentosa. It happens with long-standing uveitis patients. It can happen with, as I mentioned earlier, with trauma. So there are lots of things that make the zonules weak, and the timing of when it occurs is related. Obviously, trauma is obvious, but the others can happen spontaneously anytime after cataract extraction.